Good afternoon, everybody. My name is Jessica Tonia. I'm a nurse practitioner and legal nurse consultant with my company, FAQ by Nurse Jessi Consulting, LLC. My clinical background actually varied. Right now I'm in primary care and family medicine as a family nurse practitioner, but I also have a background in emergency medicine, critical care, home care, long-term care, and it's also fronted nursing as a certified sexual assault nurse in New Jersey. But my work as a legal nurse consultant in the legal space focuses on helping attorneys, as well as law firm, paralegal, insurance company, whatever, to interpret complex medical records and understand how clinical standards translate into legal standards of care. I like to disclose that I have no financial relationship, sponsorship, or commercial affiliation that influence the content of this presentation, and that the information shared today is based on clinical practice, professional experience in a legal nursing consultant, and published literature. So here at my learning objective, so this presentation is designed to help legal professional and healthcare provider better understand how clinical decision-making is evaluated within the legal system. We will review the definition of standard of care, discuss how it differs from the standard of practice, and examine the role of expert witnesses in interpreting medical records. We will also explore documentation patterns that frequently appear in malpractice cases and how evidence-based methodologies strengthen expert opinion. This is my program description about how we examine the intersection of healthcare standard of care and legal evaluation in medical litigation. Why expert witnesses matter. Healthcare today exists in a highly regulated environment where clinical decisions are increasingly examined in legal and regulatory context. When cases involve complex medical care, attorneys, judges, jury, and patient rely on expert witnesses to interpret a clinical action and medical documentation. Expert witnesses help clarify whether care met the accepted standards, whether documentation supports the clinical decision, and whether outcomes reflect the expected risk or potential negligence. The goal is not advocacy, but rather objective analysis grounded in evidence-based practices. Standard of care versus standard of practice. These two terms are often used interchangeably in conversation, but they have very different meanings legally. Standard of care refers to the minimum level of care that a reasonably competent healthcare provider would provide in a similar situation. Standard of practice, on the other hand, describe how professionals perform their role and responsibility. In legal proceedings, the focus is primarily on standard of care because that is what determines whether negligence had actually occurred. Precision in language is extremely important when providing expert witness opinion. Sorry, let me see. That's it. Let me show. Legal interpretation of standard of care. One important concept is that standard of care are conceptual. They are based on what a reasonable practitioner would do under the similar circumstances, such as available information that they have on hand, patient condition, clinical setting, and the time constraint. The law does not expect perfect outcome. However, medicine is complex and inherently uncertain. Poor outcome alone does not equal negligence. Expert analysis focused on whether the clinical decision-making processes was reasonable and defensible. Like, can you justify your action? Expert witness responsibility. Expert witnesses have several key responsibilities. First, we must provide objective, evidence-based opinion based on clinical knowledge and alternative sources. Second, we help educate legal decision makers, such as attorneys, about medical concepts that they may not be able to understand or be familiar with. Third, we evaluate medical documentation, clinical reasoning, and adherence to the standard of care. Finally, it is critical to remain within one's scope of expertise and maintain professional ethics. The reason being is that you want to present yourself as sort of like you're the expert in your own field, because that's based off of your credibility. Credibility is everything in expert witnesses. Documentation and liability exposure. Medical records are often the central piece of evidence in malpractice litigation. In many cases, the medical record becomes the narrative that attorneys use to reconstruct the event that actually happened. The key legal principles include, like the saying goes, if it's not documented, it did not happen at all. Omission or even like vague documentation, it does raise question of, is this reasonable? Like, did this really happen? Like, is this something that is defensible in your actions? What you want to see in terms of good documentation, it should include assessment finding. What is the assessment of the patient, how that correlates to their clinical care? What is the clinical decision-making involving that care? And the rationale for each of these treatment choices. And it's basically all the clinical clear documentation. It protects you as a provider, but it also protects the patient as well. Common risk patient pattern identified. Many medical practice cases, there are several patterns that can appear repeatedly that include, many of it involve like incomplete documentation, unclear, vague documentation on like clinical reasoning. There may have been a breakdown in communication, especially the communication between like the nurses and the provider that are involved in the care. And also, this is also key, like failure to follow up in the care that occurred. Oftentimes, the issue is not like a one single error that happened. It's kind of like a series of breakdown that occur, like we talked about, like the Swiss cheese model. Like you take one thing after another to keep going until it results into a sentinel event. The important thing is you want to recognize these patterns. If you're an expert witness, you want to recognize that there is a pattern that's going on, and how does this case in fact have merit on that. Evidence-based expert methodology. The expert's opinion must be based on structured methodology. This means relying on peer-reviewed literature, clinical guidelines, regulatory standards, and established professional practices. Expert witness should be consistent, defensible, and transparent. Courts often evaluate whether the expert methodology is reliable, not simply whether the opinion favors one side or the other. Objectivity and credibility. Objectivity is the cornerstone of expert witness credibility. The expert must avoid becoming an advocate for either party, but technically you shouldn't be an advocate for either party, but at the same time, if you're being paid by one side, you're gonna do what, you're kind of like tailoring, you're kind of leaning to that side because you are getting paid, but at the same time, you have to be able to use your own opinion, your own methodology to say whether this case has merit, is this something that we can justify in court, and how this affects the patient. But we have to analyze the fact neutrally. If the case doesn't have merit, then we have to say, like, no, it does not have merit. We can't go forward with it. It's not going to happen. But we have to look at it from a neutral standpoint and say, is this the right thing to do? Is this the merit? Was the standard of care followed? Because the big thing it comes down to is your reputation, your credibility comes down to it. You want to make sure it's consistent, it's unbiased, it's neutral, and it has to be held up under scrutiny in court. I'm going to explain the expert witness methodology, how we examine cases, and how the clinical reasoning is translated into legal evaluation. The expert witness work has impact that it's then beyond courtroom. It usually leads to improving patient safety care, a clearer professional standard, and also better understanding of healthcare concerns. By analyzing the clinical cases, we can also identify system vulnerability that may affect patient care. In this way, legal review can contribute to a broader improvement in healthcare quality. The role of the expert witness. The expert witness functions as a bridge between clinical medicine and the legal system. Our role is to translate complex clinical information into languages that legal decision maker can, such as the judge and the attorney, that they can understand. This requires from you, like the clinical expert, and the ability to be able to communicate that in a clear manner that they can understand. So this is the chart that I made, kind of like a visual that explains what happened and highlight the differences between the standard of care and negligence. So the standard of care reflects what a reasonable competent provider would do in a similar situation. And then if there's a breakdown, if something happened, it can lead to negligence. So negligence occurs when there's a deviation from that standard of care that directly involves patient care. So you're asking, if you're the expert witness, you're basically asking yourself, is there a deviation in the patient care? Did it occur? And does this deviation directly cause the injury to the patient? This is a typical timeline of how a medical malpractice case can occur. So most medical cases, they follow this similar timeline. It begins with a clinical event, usually a dental event. Something happened, like a patient fell on a unit and they broke something. That would be a clinical event that needs to be followed up on. And then there's a patient harm, realized harm that's going to be investigated. This case could take it a step further where a patient might want to talk to the attorney. It proceeds talking to the attorney, and this is where the attorney might reach out to find out, okay, I need an expert witness on fall. They come, sometimes I do a lot of fall cases, so they come to me, and this is where I would say, okay, I need medical records. I want to know what happened to the event, what happened to the patient with the patient medical history. It's usually a lot of it's electronic now, so it's usually like a big stack of it, so it's a lot to read, but you have to be able to go through it and narrow it down to see what really happened. I'm gonna evaluate what actually happened, pull out the certificate that's what happened in the event, and look to see did this case have merit? Was there something that happened? Is this something I would do in this manner? If it doesn't, then unfortunately I have to use my opinion to tell the attorney, no, it does not. But most often time when the patient is going to the attorney, there's a good chance that it may have merit. And because of that, and part of my job is I'm nitpicking every little thing involved in that case, and usually there might be a merit. So this is what I'm looking for in a medical record. A lot of times these medical records, they're huge. You're talking thousands of pages just involving a patient. It might involve the previous day at the hospital, might be a little bit after what happened if they go to rehab, so it might involve that. So you have to review. The way I reviewed it, okay, let's find out what happened. When did the event happen? What happened before? What happened after? What was the contributing factor? What medicine do you review? So it's I'm trying to visualize myself what would have happened if I was in that position? Is this something I would do? That's what I'm looking at. I'm just evaluating. Is this telling me a story? Is this complete? Is there missing? Is it kind of vague? Another thing I see a lot more, even though it does tell a story, it does sometimes the way the provider, the nurses that write a note, and I don't want to blame anyone, but it sounded like they're kind of blaming the patient a little bit. And I'm saying that because it's there could be an event, maybe they were getting a little frustrated, and you can see that proceeding before the event. And that's usually a red flag because it shows that, okay, something is going to happen here, and nobody's really dealing with it, and then a sentinel event would occur. And also keep in mind, patients can read those notes, they will see it. So you want to be as factual as possible with as much as you can. You want to try to provide a detail that's related to the patient and to what happened, and you want to be able to have good follow-up with the patient. Once I see the document and I read it, I'm thinking to myself, is this something I would do? Did this meet the standard of care that another situation that happened? And that can be hard because, it can be complex. There's usually subtle nuances like what the patient altered, like say that we have a fall and they're altered, or, they're altered, they're not getting out of bed, and they didn't have a sitter, like whatever the reason was, it can be different, but I'm trying to think, is this something I would do in this situation? I also checking to see, is there consistency? Is there a consistent history with this going on? Is everybody doing the same thing? With the previous nurse doing the same thing for the next shift nurse? If there's no consistency, there's no confession in regard to the policy of the units and all that, that raises another red flag, like, okay, there may be a deviation that's present here, it wasn't really followed. So there's a case that has merit. Fourth, big part is communication. Did the provider communicate, follow up with either the patient, the provider, follow up with the medical professional, like with the doctors and the APP, they follow up. Did they follow up on what was going on? They noticed abnormal vital sign, was this follow up on? And if so, what was the action? Are they monitoring it? Did they have to get medication? What was going on with that? And lastly, of course, we will follow to see if did this meet the acceptable standard of care. So when evaluating the case, the expert typically follow, this is the structure they typically follow when looking at the case and see, they're going to review all the medical records. They're going to review all the medical records. It can be a lot, but luckily I have AI that kind of help screen a little bit. I can go through to see and try to pick what's important, but you still have to go back and read it. Want to try to get a picture. You want to look at the big picture, like what happened from day one when the patient arrived to the hospital. What happened in the ER? Did something happen in the ER? Did something happen when they arrived before? Did what all the policy and procedure follow from the start to finish? And then I determine, okay, does this meet the standard of care? And then we compared it to other options. And then we see if there's a deviation that occur, was there a deviation? And then I try to work with, lastly, once I figure out there is a deviation, the case has merit, I try to work with the attorney to explain what happened. Saying, well, this is what happened, it wasn't really followed up on, this is something I wouldn't do, I would explain what happened. So the attorney can take it to, the defendant. Sometimes, I've been in a couple cases where sometimes the attorney, because we have these conversations, you're kind of expected to testify, and they could go to trial, but trial can be expensive. So a lot of times the attorney, if I'm working for the patient, they would go to the defendant and say, hey, this is what happened. They're still negotiating. They may just choose to say, hey, we'll settle out of court. And then you don't have to testify. But usually they settle out of court based off of the reason that what happened. So the key takeaways is the standard of care are the foundation of the medical negligence, for evaluating medical negligence. Documentation play a role in shaping their legal narrative. A lot of the things that have changed recently is based off of what happened in the court that becomes the standard of care. Expert witnesses must rely on evidence-based practices and objective analysis. They have to be neutral and they have to be evidence-based. This is something they have to back it up with peer-reviewed journals and all the research and clinical guidelines that's involved. You want to use that's why attorneys like to use their testimony to help enhance their cases, to say, hey, this is what happened, this is what should have happened, why the standard of care was met in order to advocate for the patient. And here are my references. And that's the end of my slide. If you have any questions, this is my LinkedIn, my website. Please connect with me. Yeah, any question? Yes.
I have a quick question. You said that, when you were looking at the documentation, it feels like that the nurse or whoever is writing is almost like blaming a patient. I think it's coming from a place of nurses are so much told that you have to protect yourself,
Yeah.
protect your license.
Yeah.
Unconsciously, a lot of times do it. I don't think anybody wants to blame the patient or
Right.
anybody wants to go ahead and, write those things because they want to. It's just that they are trying to protect themselves. So what would be a recommendation, even when you go into factual side, if a patient had something wrong, they had something wrong. Like a lot of times I do get diabetic patients who have recovered from DKA, and if they don't control their diet, they are going to likely go back into DKA.
Yeah.
And we don't want to have those instances. So when we are writing, we don't want to blame them, but we do have to still give facts. So at what point can a document, even with factual ways, can sound like a blaming a patient? Can you guide a little bit more?
It's all about wording. Like you can see, I can see in the narrative note, it'll say something like, the patient was told not to get out of bed, the patient must remain in bed. It's like certain wording and verbiage when really like educating the patient about using the call bell. You want to kind of like, I guess use it like a nurse speak, but it's like, you don't want to like redirect it on the patient. Kind of like what we've been doing, like educate the patient about using the call bell. We'll continue to monitor, not like, well, the patient was told not to do that. Patient refused. Even wording like refuse versus decline. When you hear the word refuse, that sounded like somebody's combating, they're fighting you. They're angry. You're clashing with each other, when that may not be the case. If you say, well, the patients say they decline, they're like, oh no, I don't want that, they're declining. They're being nice about it, and they're saying no at this time. They're not clashing, they're just, at their right, they can decline. So it's like, I pay attention to what the wording, how it's been transpired, because that creates a big picture of what's going on. And unfortunately, that's all I have, because I'm not there. I wasn't there. I'm the third party that's coming in to say, hey, what's going on? What happened? So that's why I rely on, unfortunately, we have to try and document as much as we can, but it can be hard because the patients do read it. Everybody can see it. So you have to be careful how you document. At the same time, you have to tell a story. That's the only thing that's going to cover you. That's going to cover you.
Thank you, that was really helpful.
Can you speak to, I've noticed more and more documentation is being, especially with, so my hospital transitioned to Epic. We saw more and more, thank you, sorry. More and more charting I'm noticing is in flow sheets, and so we're clicking through things, and there are fewer and fewer notes.
Yeah.
The only notes I'm really seeing when I take students to clinical, for example, are from providers, physical therapists. I'm not really seeing a lot of nursing notes anymore. And so can you speak to how that impacts your case when you're going through there?
It creates a very vague picture, because now I'm using my opinion. Flow sheet does not really tell much of a story. Anyone can click, and anyone can be A time 4 and still be having ultramental status. So you really need to tell a story with a narrative. Unfortunately, flow sheet, that's just a vague documentation. It doesn't really tell what happened during the shift, what happened to the patient, did something change, did they have a medication reaction, was there a med error? So now I have to try and interpret it based off the flow sheet. I'm looking at it, I'm like, well, it looks like a normal day. And then I'm looking at the patient history, like, well, say they came in like short of breath, and you're telling me they're A time 4, but they're trying to get out of bed. They could be confused, like, well, they're not, they may not be A time 4. So it's like, I'm trying to take guesses, I'm trying to investigate and figure out, and this is where the attorney, they may have to do more subpoenas to try to figure out really what happened. This is where the nurse eventually, it's going to lead to where these nurses are going to get deposed on court. they're gonna drag them in and try, and that's where the credibility can be ruined, because I'm basing off the flow sheet, and then I got you on stand, you're saying something different from the flow sheet. It's not, where's the picture, and that's where the case is gonna get lost. It's gonna have a big effect. Yeah, that's where you have to like try the best you can tell a story. If you tell a story, you don't wanna be on stand. You don't wanna be in that position where the attorney, they're literally like nitpicking every little thing about you, and then it's like, yeah, unfortunately, I've seen those flow sheets, they don't really help with the story, so, yeah.
I think it's interesting, your comment about refusing back here.
Yeah.
Because that's actually the language that's embedded with our drop-down menus, like in charting, that patient refused medication, patient refused bath, patient refused.
Yeah.
And so that's interesting because we've embedded that within,
Yeah, I mean,
unfortunately.
yeah, unfortunately, yeah, but and unfortunately, when I see the word like refused, I think, well, were they fighting with you on it? Like they adamant, and that can, so when I'm looking at it, I'm like, oh, are they combative? Is that why they fell? That's what happened? So sometimes, even in EPIC, some of these words gotta change. Because you wanna be, it protects you, it doesn't make you look as bad. And it also protects the patient, because at least the patient's probably gonna say, I never refused, I just said I know. So, it's like, I'm guessing based off of, almost like I'm trying to pull it out of thin air.
That means education, communications, very important, right? With the patient. Educate, communicate, engage, right?
Yeah,
So that's very important because even simple
you wanna
terms.
document as much as you can in the room, like how they're behaving, just because they're nonverbal
Exactly.
doesn't mean they can't gesture. They can't get up out of bed, they can't move their eyes, I mean,
Right.
that's the stuff, you wanna really document every little thing that's in that room, how they're saying, how their skin look, and all that. Just because they're nonverbal doesn't mean they can't communicate any other way.
Right.
Maybe they're able to write on a notepad and stuff, we don't know. Maybe they can't, you have to document all those things.
Right.
So, 'cause that tends to be a problem, because if the patient's nonverbal, how do you know the family member's not gonna say,
Right.
what did you do with my family member? And it just leaves room to open an interpretation, then I gotta read it and be like, well, what happened here? So you wanna document every little thing, like, well, when I gave this medicine, the patient nodded their head, yes, like they understood. Or maybe the patient gave a wave as if to say, no, I don't wanna do this. But it's like, you have to document even behavior, just document what they're doing. Yeah. Any other questions? Oh.
Just kind of, I know we had a pretty controversial legal thing, I think, at Vanderbilt, that was like a nurse had given vecuronium instead of Versed in a procedural area and was a sentinel event. And I just wondered, it kind of came out that they didn't have safeguards in place, that would give a hard stop that you're about to give a paralyzing medication. Is there any liability on healthcare systems for things like that?
But it's harder to do that. It's harder to sue the hospital versus the nurse.
Okay.
That's why, I'm sure the family tried to do that, because it goes back to the equipment they were using. That's the liability with them, the medical device error, technically speaking. It's the hospital's fault for buying it, negligent buying the product. And then finally, we have the nurse that actually did it. Sadly, if the attorney, and a lot of times these family members, they don't have money, they're not paying for the attorney. A lot of times they're waiting for the cases at the end so the attorney can take a percentage. So the attorney's looking at it like, what's the best outcome? How can I get a win for my client? So that's why they went after the nurse. It's kind of hard to go after the hospital system because they're going to cover it up. They're not going to, and if anything, they're going to say, well, we trained that nurse how to, it's very easy for the healthcare system to do that. And the medical device, the one that made it, they're going to say, well, you didn't follow manufacturer recommendation. So that's how it always comes back to us, unfortunately.
Okay.
It always does. And that's why we have to try to protect ourselves. Yeah.
Thank you.
Okay, thank you. Thank you.